Now we'll turn the time over to Dr. Alessandro Gronchi, goes by Alex Gronchi, Chair of the Sarcoma Service, Department of Surgery at the Istituto Nazionale dei Tumori di Milano. He's very, is that okay? He's very involved in the consensus paper, as you heard, and he's going to talk about active surveillance, or watch and wait, it used to be called, as a desmoid tumor treatment. Thank you.
So thank you very much, Winnie. Thank you for the invitation, and I'm really happy to be here with you today discussing this. And basically, this falls very well after the presentation you heard about medical therapy, because it basically is the other side of the coin, let's say. So it's where you really don't need not to do anything, because I mean, when you are dealing with desmoid tumor, which is indeed a tumor, which is indeed a scary thing that you actually may have in your body, in the end of the day, what you need to receive is something that doesn't make your life worse than what the tumor does itself. So if you get a drug, if you get a treatment, if you get surgery that make your life more morbid, make you more symptomatic, and what the tumor was actually doing, that's bad. And this is something that we learned over the years, in the recent years. We didn't know. You know, this tumor originally was called low-grade sarcoma, had been called with multiple names, and only at the end of the last century, basically, it was finally described as an intermediate malignancy, as it was clearly shown at the beginning of this presentation today. So it's an intermediate malignancy, meaning that it's a tumor that can grow locally, can become invasive, can determine symptoms, but it doesn't happen all the time, right? It doesn't happen all the time. So you need to understand whom to treat, because I mean, most of the time, survival is not affected by the disease, meaning that you will live forever. No one lives forever, in fact. But in terms of what the disease can cause, it will not be the cause of your death. You will die of anything else. Most of the time, I'm not saying 100% of the time, but I say 99.9% of the time, if you consider all desmoids around the world, the patient will not die of it. Occasionally, they die. I have a patient who has recently died, but it's 1 out of 100. It can happen, but it's very, very rare. So since this is the case, well, you really need to consider what the quality of life of your patient is. And so in the past, we are undergoing multiple operations with sometimes miserable quality of life because of the operation, much more than the tumor. And this is, and let alone when surgery was combined to radiation therapy, because the combination of the two that can be helpful in some situations can really cause symptoms, and sometimes also can cause radiation-associated tumors over time. So that's why radiotherapy is not used anymore that much. It was used to be used, but now it's used far less. So yeah, so we started looking back. So this is what is called retrospective evidence. What is a retrospective evidence? It's something that you at some point decide to look by thinking of what you have done and revisiting what you have done to understand whether you did it right or you did it wrong. Because doctors also, most of the time, you have to ask this, and sometimes they did it wrong, simply because they didn't know. It's not on purpose, of course. But they thought it was, well, if you go back in the 18th century, 19th century, doctors were doing many bad things to their patients, even if they thought they were benefiting or tried to benefit them. So this way of thinking, so thinking back, is a very important one to start generating new ideas, hypotheses, but then you test prospectively. You heard that the best evidence is the prospective randomized blah, 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 right? Meaning that you basically try to test your hypothesis in an unbiased way, right? Just looking at what you look, deciding upfront what you want to see, and then comparing different groups. But when you look retrospectively, you look at what you've done, right? So, and who was the first to consider that desmoid may not have behaved or do not behave or didn't behave like regular malignancies? Someone, I think memory is not getting, called Murray Brennan. For those of you who have never heard about him, he has been one of the most thoughtful investigators and surgeons in sarcomas. And by the way, I'm a surgeon. I'm talking about non-doing surgery, so I am really unbiased here. And he was a surgeon too, and he was really smart. And he was one of the first to see, well, I saw spontaneous growth arrest in patients who had recurrent desmoid, and we have been operating multiple times. At some point, we didn't know what to do, and we simply didn't do anything. The tumor stopped. Now, later on, first a French surgeon, another surgeon, Sylvie Bombalot, tried to publish. She went on this idea of not operating desmoid, and she did a series of her own of patients, not this one. And now I explain what this means. But not this one. And she did send this publication, this report, this analysis, retrospective analysis again. So she looked back to what she did and see patients, whether they were doing well or not with no operation. And nobody wanted to believe her. They made a fool of her, saying, oh, she says so because she can't operate desmoid. That's it, right? Until she ended up by publishing this first report in a very small journal. And then we got together, and Marco is here with Cindy Bombalot, put together a larger series of almost 140 patients. It's basically the size of the randomized study on neurocancer study, exactly the same size. So 142 patients who were surveyed in the two European institutions, Gustave Roussy in Paris and National Cancer Institute in Milan. And this is the curve, or what is the curve? This is the progression-free survival curve, meaning that, you see now, you don't see. Meaning that over time, you see months, over time, patients who stay on the curve do not progress. So if the curves go to 0, all patients progress. If they stay up, you see on the axis is 0 to 1. These are 100%, 80%, 60%. So basically, some 50% of the patients at the 5 years time point had not progressed, even if they didn't do anything. 50%, 1 out of 2. The problem is, who is the one who doesn't progress? Who is the one who progresses? Right? And this experience was replicated, and I don't want to go into details, even later in another larger series. So this is retrospective evidence that is usually not believed a lot, helps generating ideas, but then you need to test it prospectively. Why is not believed a lot? Because when you publish your retrospective observation, most of the time you're biased. You tend to see what you want to see. If you don't believe in surgery, I show you the best evidence that you should not do it, simply because I pick the one I like, the examples I like. And that's why, even if I try to be very objective, the scientific community doesn't trust a lot retrospective evidence other than generating ideas. So which are the prospective evidence? So the one you generate from scratch, and the first is the sorafenib randomized study. So what did the sorafenib randomized study? This is called waterfall plot, because this seems a waterfall, right? So we say the waterfall plot about response. This is the sorafenib, the orange one is the sorafenib, right? The 50 patients on sorafenib. And you see every pillar is a patient, and it is depicted the degree of regression, okay? The percentage is there, right? So 100% regression, like the first pillar on the left, on the right, yes, is 100% regression. And then the rest, you see the scale, right? They are putting by the amount of regression. This happened also on the placebo. You see the light blue one. So even in the placebo, So this means that either patient was secretly taking something, certainly not sorafenib because it was not available, something that you don't know, or the placebo works, so you may actually market the placebo, or the tumor regresses spontaneously. Whatever it is, we don't know yet, meaning that we don't know yet. So you see a lot of regression here. And in the same time that we were doing this randomized study, we were in fact doing an Italian observational study. Actually, there were 3 parallel observational studies run in Italy, France, and the Netherlands. 2 of them are fully published. One was just reported at a meeting. They all say the same things. And you see here the same waterfall plot, okay? You see on the right side, the regression. And these patients were really not taking anything because they were checked, monitored, they were actually having a lot of questionnaires. They were not really taking anything. We didn't even have a comparator. This was just an observational study of patients with a primary diagnosis of desmoid who were initially managed by active surveillance alone. And this showed a 25% initial spontaneous regression with the so-called progression-free survival, so the same things that we saw in the other curve. So basically a curve that depicts you patients who progress and those who don't progress. Basically, those who remain on the curve are those who don't progress, and the 3-year time point, 50% of them didn't progress. I did 50%, and this remained then stable because the curves doesn't go down anymore. Basically, it flattened out, meaning that if you are not progressed after 3 years of observation, the chance of progressing further is basically almost 0. And this is actually by mutation type, but I'm not going to talk about this. What also we looked at is treatment-free survival, meaning how many patients of those who progress in general need a treatment? Some 30%. So every of the patients that walk in your clinic, 1 out of 3 will need a treatment, 1 out of 2 will progress. The same was found by the Dutch. This is the Dutch observation study. This is another way to look at is the opposite, meaning this everyone who's on the curve is a patient who has received the treatment. So third is incidence of treatment, meaning that in 3 years, 30% of the patients need a treatment. Same results. And these are the French data, same results. Progression-free survival, meaning the patient who progress at 3 years are less than 50% and remain stable like this. So, well, very compelling results to say that not every desmoid patient need a treatment. The question is, who are those who need a treatment and who are those who don't? But that's another question. And finally, also the neurogases study did see the same. Although the proportion of patients this time is on this side, the placebo is on this side, the neurogases group is on that side. You see a lot of responses. This is still a waterfall plot showing the degree of reduction. Green ones, complete remission, blue ones, partial remission, and then minor remission. Okay, and until on the left side, on the left far end, there are the progressions, right? So if they go up, they are growing. If they go down, they are regressing. So even here, they saw regressions. They saw less regression here, simply because they were including only patients who were progressing at the time of study entry. So the occurrence of regression after progression is still something that can happen, even if it happens less often as compared to what you see at the beginning of your story. And indeed, this was seen also in our series. So basically, you see in the light blue, okay, after those who were, is what happened after progression. So those pillars that were actually going up then went down, also by a lot. And this is instead it's called a spider plot. It's another way to look at this at the patient. Every line is a patient and tells you his story over time. So this is 60 months from the beginning. It grows, and then it stabilizes. You see the first line, and this is all the other patients who had this were included in the Dutch study. Basically, you see here that the Dutch group split the observation, this plot in 3 groups. Those who are having a partial remission from the very beginning, green ones. Every patient is a line. They're all going down. The stable ones, the blue ones, they all basically remain stable. And the red ones, all who progress at the beginning and then regress. So A lot of regression after progression, a lot. Meaning that one patient out of those three who is progressing will eventually regress without any drug. Well, again, compelling, this is just an example. You see the white thing is the tumor which is growing from November 2015 to July 2016, and then it's going back up to December 2018 without doing anything. He didn't take anything. Not even in Italy, we have a lot of holy water. But she didn't even take, she was not a holy water believer, so she didn't take even that. A lot of holy water. So that's it. And now it's actually 5 years after, and she's still totally fine. So we put together the two series, I mean, the Italian and the Dutch, to try to understand more, to dig more, to try to understand why this happens, if there is any correlation with some, for example, the beta-catenin mutational status. So beta-catenin tells you who are the patients you need to watch more closely and those you can actually watch less closely. It has also implication in terms of how many scans you need to undergo. I mean, 3 scans a year, 4 scans a year, 1 scan every month, 1 scan every year. It's a big difference because, I mean, also the anxiety which goes with the need to take an MRI, your life, your work, everything actually you need to invest to do all these scans has implications, the decision, right? So we looked at this, and what we found is that, number one, the final regression rate, if you include initial regression and post-progression regression, is not 25%, it's 46%. So it's a lot. It's 1 out of 2. The problem is what do we need to do with the other half? So if the tumor goes away by itself, fine, we're all happy. But then we need to treat the others, right? But at least we don't over-treat those who don't need to be treated, as we were used to do, also by doing a lot of surgeries that probably were not really needed. And also there is a difference. You see these different colors, just to say that there is a difference in the risk. Again, the curves that go down are those who have less patients who don't progress. The those who remain up are those who include the patients who instead do not progress. There's a difference between the different mutational status. So there are some mutations that indeed seems to be associated to a higher risk of progressing. And that's important to know because these are the patients that you need to follow more closely. Larger tumor size, extremity location, and S45 mutation were associated with worse outcome and worse progression risk on active surveillance. Now, this happens also in intra-abdominal desmoids that are, in a way, those who have a more problematic course, along with the head and neck ones, because of the location. So the location is critical because they may cause life-threatening symptoms. So while you will never have a life-threatening symptoms for a tumor located in a foot, you will certainly have it if the tumor is located in the neck, because it may compress the trachea, or you have it in the abdomen, in the bellies, where there are vital things that if they are compromised, there is where you can have a problem, and then you need treatment. But also in the desmoid, intra-abdominal desmoid, there's a chance that you don't need surgery, which is in the 40-50% range again. So to conclude, active surveillance is considered the primary approach because 50% of the patients do not need any treatment. And this is usually something that requires some time to understand, because until we get the marker to say you're going to be the one not progressing, you are going to be the one not progressing, the time is the best way to look at this. Well, can I go back one? Yeah. Extremity location, large tumor size, and 45F mutation are the one as what we so far have seen to be linked to be associated to the worst outcome. We need to be extra careful for the head and neck and intra-abdominal location. But the availability of new drugs may change the way we do these patients, because everyone would love to have the lump, the tumor, go away sooner rather than later. Right? If you need to wait 5 years to get for the tumor to go out, and have a drug which in 30 minutes get it out, melt it out, I mean, I would certainly take the drug, even if it goes away by itself. So the decision of whether to treat or not to treat a patient or the tumor will depend also upon the drug will become available in the year to come. Because the less toxic, the more active it will be. We may decide to use them earlier rather than later. So it's not something that is just written in the stone. It doesn't mean if 50% of the patients will have a tumor go away by itself, it does not mean that they will never be treated if a drug is available. Because sometimes this requires also to be patient and to wait and also to suffer pain that needs to be treated and so on. It doesn't just go away by itself without any we went together just to say that this is the way the new algorithm will look like when we will be finished it. But every initial approach will pass by the assessment whether active surveillance is worth or not, but most of the patients will undergo initial active surveillance rather than being treated with any possible treatment. Because time today is what we counsel as the best, and we'll see what happens in the future, but this is it. And then of course the treatment will vary according to the different locations, as it was said. Yeah, so it's important to discuss this, and also the way you live with the tumor will be one of the things that will impact the choice. No? It will be considered, it will be factor in the treatment decision. So patient will, I mean, it is true for every condition, but in this specific tumor, also the patient will is one of the most important determinant of what you need to do and what you don't have to do. But stay away from surgery. And that's it. Thank you very much for your attention.
That's from a surgeon.
To people who have experienced spontaneous regression, does it ever down the line regrow again or start up in a new spot?
Very, very good question. And the answer is,
Repeat the question.
the question is, if a patient experiences regression, does the tumor ever come back and reprogress? The answer is 99% of the time they do not. I've seen occasionally this to happen in very, very, very few patients. So most of the time they basically live the rest of their life without any other needs. Very well. Now I need to do this. Okay. What is the updated recommendation for FAP-related desmoids? So yeah,
For what?
for FAP
Oh,
FAP-related desmoids. So familiar adenomatous polyposis-related desmoids, the so-called familiar desmoids. Recommendations are pretty much in line with the recommendation we use for sporadic desmoids. So observation with the only caveat that most of these desmoids in fact occur within the bellies. So they affect the mesentery, they affect areas of the belly that are critical. So they may need to be checked, to be followed more carefully, and they may need to start an active therapy earlier rather than later, because growth of this tumor may cause symptoms that become life-threatening, meaning that while in the periphery, in the extremities, you may wait even the tumor is growing because it can subsequently regress. This may not be very wise in the abdomen, because during the growing phase, it may cause symptoms that then become more problematic to deal with. Have you noticed any changes in the number of desmoid patients since the start of the COVID pandemic? Did the pandemic impact research or clinical trials at all? Well, I was not in the best place to look at this, because I work in the standalone cancer center that didn't treat COVID in Italy. By the way, you know that the outbreak in the Western country was in Italy, actually was in Milan, actually was nearby Milan. So we had a very bad time at the time of the COVID when we started. However, the cancer patients were reserved as kind of areas that were COVID-free. In our place was one of those areas COVID-free, so we saw a lot of patients all the time. So, but it's yes, the answer overall is yes. So patients who didn't really go to hospitals or were scared to go to hospital during the pandemic, and so when we saw them, sometimes, well, the stage of the diseases tend to be worse.
Okay, thank you so much.